and I'm a senior research associate at Sustainable Development Policy Institute, which is a research think tank, a leading research think tank in South Asia. And on behalf of STPI, I welcome you all to the discussion on preparing the next generations of tobacco control advocates, and offering this particular seminar is on offering help to quit tobacco use. As we all are aware that Pakistan has been a signatory to FCTC since 2005, and signatory countries are obliged to treat tobacco and its dependents. WHO, which is World Health Organization, also helps in establishing tobacco cessation services and support to quit tobacco use. Indeed, quitting tobacco use is challenging, and around 780 million tobacco users intend to quit tobacco use, but only 30% of them have cessation tools available around them. Counseling and medication can double the chances to quit, and around 32% of the total population of the world's total population in 23 countries have the comprehensive cessation services with full or partial cost coverage to assist tobacco users to quit. Public health professionals have great potential as compared to any other group in society to help in reducing or quitting tobacco use. However, the situation gets worse and much complicated when the health professionals also use tobacco. Studies show that very few people truly understand the specific health risks associated with tobacco use, and which includes cancer, heart diseases, lung diseases, and stroke, etc. And brief advice from health professionals can increase the quitting success rate by up to 30%, which may be increased up to 84% with intensive advice. In today's discussion, we aim to deliberate on the three main aspects. Number one is the global and regional best practices in cessation. Number two is strategies which could be adopted to target larger segments of the population. And number three is the roles of self-motivation and commit to quit. With this brief introduction about today's discussion, I would now request Dr. Wasim Iftikhar Janjua, who is advisor to the Health Center of STPI, to give us an agenda setting presentation, and after that I'll move on to the speakers. Over to you, Dr. Wasim.
So can you see my slides?
Yes,
yes, these are visible.
Thank you. Bismillahirrahmanirrahim. So as you are aware, today we are going to talk about offering tobacco cessation or quitting help. And my apologies, Dr. Sumeda. I think you will be the next speaker. I understand that you're not feeling well, but definitely we'll let you in. So as all of us are aware that within 2 weeks of quitting tobacco, lung functions increases, and after 10 years, the risk of lung cancer is half that of the smoker. And it takes further longer time to become a normal human being without any lung issues, or someone who has never smoked. I was just listening to this report, which is being launched right now on another forum, that is the World Health Organization report. And like Wasif said, that the last number that we had was around 30% in cessation programs. So now that number, this report, which is just being launched, that number has increased, and that has gone to 35%. But still, it is one of the low-performing MPOWER measures, which needs further attention. Incidentally, we do not have any cessation programs going on in Pakistan, and a major reason for hosting and requesting all the worthy speakers to this webinar is that we want to learn from your experiences, best practices that we are having regionally as well as globally, because all of you have worked, in cessation for a long time. In Pakistan, we have more than 24 million active users. Some figures are even higher, and out of these, 160,000 annual deaths are reported, which are directly attributable to tobacco use. Unfortunately, almost 1,200 children start smoking tobacco use every single day. Regionally, in Pakistan, the cigarettes and other tobacco products are cheapest when they're compared to other countries in the region. Incidentally, a health burden of 615 billion rupees is mounted on the national exchequer because of tobacco use. And almost no quit or cessation services are available in public or private hospitals, barring one odd clinic, which is also located in a private facility in Karachi. So we are in Pakistan. We are, there is a big gap. There is a big void in this area, and we are just going to start working on this aspect of the MPOWER strategies. Like I told you that around the world, there are 2.4 billion people. Now that number has also increased, who are covered because with these cessation policies. Chances of quitting tobacco can more than double with the right support provided to all those who are aspiring to quit. And quitting tobacco has major and immediate health effects. And helping people to quit has more impact when efforts are combined with other MPOWER or tobacco control strategies, like we just saw, or all of us know, that is enforcement and taxation, raising the price, etc., and media coverage also. So the cessation services, they can further add on to the better health. Global targets to reduce tobacco use and related deaths are unattainable if quitting help is not available or is not provided to audience. There are a few things that I want to talk about, which may more be relevant to Pakistan or to the region, culturally as well as psychologically. For example, glamour tobacco industry has all along attached, a glamour or that Marlboro man image to smoking. So young men and women, they tend to follow this, and they tend to start smoking. We also noticed a class or status symbol especially since we have started seeing these electronic cigarettes or vapes, as we know them, or other HTPs, since they have started appearing. So these are considered as a class symbol. Anyone who is, because they are expensive right now, so anyone who is using those is considered to be from a different or a better class. Some of the tobacco products, they are associated with the culture also. For example, smokeless tobacco, which is Maswar in Pakistan, that is considered as a cultural taboo, and it is very difficult to implement MPOWER strategies or tobacco control policies when it comes to products like this. And this perception has been created by tobacco industry, and it is being reinforced every single time whenever there is a taxation increase or there is a price increase in this. Incidentally, there is also a slight stigma associated to visiting the clinics, or there may be quit clinics for tobacco or for other drugs or dependents. So people usually tend to avoid these kind of places in our culture setting. Then depression and anxiety, you must have noticed psychologically, many people say that I just smoke because I'm depressed, or I want to avoid anxiety. But what happens is that when they start smoking or they try to quit, they again fall back. There is a relapse of depression and anxiety. There is a financial strain. This is very interesting that this is not only a cause, but the effect of also the smoking as well. So if you start smoking, there'll be, it'll take a heavy toll on your pocket. And then, when you start smoking, it causes further, deterioration in your financial status. Almost all the smokers very clearly understand that there are multiple cancers associated to smoking. And with this, we've also seen that our health systems, they're overburdened by multiple pandemics, one after the other. coming in the society. And these and smoking, or the cases of smoking or cancers caused by the smoking or tobacco use, they put further strain on them. Finally, this very interesting aspect, which was mentioned to us by Dr. Jain from the union, that smokers are always a minority in the society. So we need to understand that majority can, prevail over the minority. We can convince, even in a household, if you see, there might be one odd person who is a smoker. So the majority can always influence their behaviors. Just a few words regarding the services which we aspire, or we hope that will start in Pakistan very soon, within the next few months. Basically, we are going to adopt a population-based approach, targeting major portions of the population, possibly at the national level. We'll also plan, or this is also a good practice, to establish a national toll-free quit line. Then brief cessation services by the primary health providers, as well as by secondary or tertiary health providers will also be there. We will also start the mobile cessation services, whereby multiple apps would be launched, or the services to those who aspire to quit will be provided with the help of mobile phones. We also look forward to integrating our cessation programs with the NCD programs. And as for sustainability, we also look forward to the taxation money being diverted towards cessation programs, so that something which is caused by tobacco use is spent to help people quit tobacco also. And the cost coverage, some countries are providing cost coverage to cessation, including NRTs, but we do not have it in the immediate plan. Maybe in the long run, we'll start looking, because right now in Pakistan, the cost of NRTs is excessively high. Just received this map. Like I told you, the report is being launched as we are speaking. And in our neighborhood, we can see that we have an excellent example in the shape of India, who have they've progressed immensely, and all these blue countries, they are the highest performers in cessation services. So another reason for inviting our Indian friends and experts is to learn from their experiences, and we'll continue to invite them and look forward to their guidance and advice as far as Pakistan starting the cessation program is concerned. Thank you so very much, and thank you for your patient listening, and we look forward to your kind participation. Thank you.
Thank you very much, Dr. Wasim Janjua, for a very self-explanatory sort of presentation. As per plan, we have Dr. Sumeda Kushwaha for her brief remarks. Over to you, Dr. Sumeda. Dr. Sumeda is a Canadian-based Indian national, and she has expertise in cessation services also. Over to you, please.
Thank you, Wasim. Thank you, Wasif. The notable people on the panel who've been my seniors and my teachers and mentors. I'm very happy to see that Pakistan is moving in this direction, because I'll briefly summarize that some of the research shows that, as Wasim, you were saying, that doctors who are smokers or tobacco users do not want to help people quit. They have that inherent tendency. So I conducted a research about 5 years or 7 years back, where I found out that since tobacco cessation is not taught in the medical or the dental curriculum, people do not have knowledge about it. The medical professionals do not have knowledge about it. Second, they do not have the skills and the confidence to do counseling in their clinical practice. Third, they don't have time to counsel patients one-on-one, because counseling takes time. And the last is lack of remuneration. So doctors find it easy to prescribe medicines for all the NCDs, but they do not have the inherent knowledge, skill, confidence, and the remuneration to do cessation in their clinical practices. So this was the finding of the research, and we were thinking that we should do something. And I am very high on technology, and we started asking people, and we found that a systematic review that we did, that there are n number of apps which were there to the user, to the end user who uses tobacco, but the quit rate was abysmally small, of only 2%. So people are using cessation services, maybe 35% want to, but how many are successfully able to quit was only 2%. So we understood that if we have to really understand the crux of the market, the crux of the entire health system, we have to train our primary health workers, our nurses, our medical and dental administrators, doctors. And in our country, we also have indigenous doctors like Ayurvedic people, like homeopathy. So that entire cadre of health professionals need to be trained, not just doctors. So this is why we developed this app, which is called as the START app, which is Stop Tobacco with Assistance and Relive Today. And here, what we are trying to do is launch it both on the Google platform and on the Apple Play Store, so that it is available to both the people. And if I just show this to you, the health worker can register on the app, and you will have the information of which area, which primary health unit or community health unit or hospital is using this. This can be widely used across private, public, and the non-governmental sector. And here what we are doing is we are training any lay health worker to become a tobacco cessation counselor. So just giving you a preview that you have the tobacco cessation database. There is an inbuilt chatbot, because a lot of times what happens is the patient comes to you and the doctor doesn't even know the answer to it. So cessation is not taught in curriculum, right? So there's a chatbot inbuilt in it, and you can view appointments. There is a calendar, there is a chatbot, and just look how the National Tobacco Control Program in India has a case history. So everything is documented for the patient. So now the health worker is registered. Maybe SDPI will know how many people we are training. And now the health worker goes to maybe a community or maybe sitting in a hospital. Now they are able to register the client or the patient, as is said in medical terms, where they're taking a total case history of the patient, and they are understanding what is the severity of addiction. So, whatever, smoking, smokeless. The systematic review that we performed also showed that all the mobile apps or digital interventions that have been developed are towards smoking. There is nothing towards smokeless tobacco. And we have crores of people in our countries who are also using smokeless tobacco. So most of the interventions globally, not in India, but globally, are directed towards smoking. So we are able to register the entire case history, and we are also able to calculate the amount of money the person will save when they stop quitting, when they stop using tobacco. And then there are also tests for clients. For example, what is a pre-motivational assessment? What is the readiness to quit? What is the Fagerstrom nicotine dependence test? Because when we are counseling patients and we tell them, oh, you're addicted to tobacco, nobody agrees, right? So all these tests are kind of inbuilt in the app, where you can keep recording and seeing the progress of the patient. And also you have the WHO quality of life assessment inbuilt in the app, where you can keep measuring how much has the patient kind of improved after your counseling. So it becomes all evidence-based, it's all data-driven. And you also can do a monitoring and quality evaluation, where you are understanding that my patient's evaluation or baseline was this, and now I've counseled him or her for 3 months. How am I improving, or how is the patient improving? So this type of things are inbuilt in the app. There are also, and the entire system is based on CBT, that is the cognitive behavior therapy, and MI, that is motivational interviewing. So this app will give you step by step, what do you do in session 1? Once the patient comes, I did a qualitative study and we understood doctors just say, you're going to get cancer if you smoke. Next thing, there's nothing, because the doctor doesn't know how to counsel. So a lot of cases that we saw with health professionals was that it's a fear-based counseling. They're just trying to scare the patient. So here what we are trying to do is step by step, what do you have to say in session 1? What do you have to say in session 2? What do you have to say in session 3, 4, and 5? Accordingly, it is given, and it talks about, and this is derived from 4 different sources. One is the WHO website. Second is the National Tobacco Control Program of India. Third is CAMH, that is the Center for Addiction and Mental Health in Canada and the University of Toronto. And fourth is a general research that we did around counseling, where we all learned counseling at Johns Hopkins, where Wasim and I met. So the other course that I did was more around this. So this is giving you a step-by-step thing. I'm just running through the slides, but I just want to tell you that through this initiative, what happens is that once we train the health worker of any cadre, not just doctors, of any cadre, we give them something which is called as the LMS system, which is a learning management system. Now, what we do is we give them 3 modules to complete, which doesn't take more than 15 to 20 minutes. And then they have to do a small questionnaire, a small quiz of 10 questions. And once they clear these 10 questions, they get a certificate. So what we are doing is we are certifying, or we are kind of enabling any health professional of any cadre to be trained as a tobacco cessation counselor, not just doctors, because we cannot keep adding burden on doctors and dentists. Although we have the concept of something which is called as the teachable moments, which has been very highly documented in medical literature and scientific literature, where, you know, people say that dentists especially, you know, since they have total access to the oral cavity, they open the mouth and they know whether a person is a smoker or a tobacco chewer. So they have teachable moments, even for non-communicable diseases. If somebody knows it's a patient of stroke or heart attack, the 5A strategy has to be kind of integrated into clinical practice. Again, I'm talking about research. People, you know, or health professionals ask, they assess, but advise, arrange is not done by health professionals. So we are trying to counter the problems of effective integration of the 5A technique into primary healthcare, into all levels of the entire health system, healthcare system, where you don't have to go out of the way to buy something, or you have to do like extensive effort, but it's strengthening of the manpower at all levels. And I think I can share the link of the app, Wasim, and Wasif with you, or Kuram with you, and you can, you know, just try and test it. Just as an FYI, King Edward College in Pakistan has been in constant contact with us, and they want to kind of pilot test this. So I would request all 3 of you, you know, to maybe use it, maybe train a couple of people, and whatever help is required from the Canadian side and the Indian side, I will be more than happy to provide it.
Thank you so
Wasim,
much.
over to
Before
you.
you go,
Wasif, over to you.
Thank you so much, Smeda. And while listening to you, I was thinking that I'll certainly be bothering you over and over again on this. And this seems like a great help. Thank you so much. We will definitely get in touch with you.
Thank you very much, Dr. Wasim, for your very valuable endorsement. This was Dr. Sumedha Kushwaha, and she was the CEO. She is CEO of Global Initiative for Public Health and Innovation, and she discussed about the digital intervention in tobacco cessation. Now, I would request Dr. Rakesh Gupta. He is the President and Director of Public Health Strategic Institute for Public Health Education and Research. And he'll talk about myths about tobacco cessation with e-cigarettes. Without wasting much of time, I would now request Dr. Rakesh Gupta to please take over.
Yeah, thank you, Dr. Wasim and Dr. Wasif, for the invitation. Is my screen visible to you? Is it visible?
Yes, sir.
Yes, sir.
With
Okay.
a humble request that I'm not doctor, by the way.
And so everyone in tobacco control is called a doctor, so it doesn't matter. So there, actually, I wanted to talk about these myths associated with electronic cigarettes in a symposium. Actually, I attended on 15th of August. It was organized by I Can Care. They are doing a wonderful job in tobacco cessation in Noida. So I prepared this slide, this PowerPoint for them. So there are certain myths. As you all know that the tobacco industry now, they are losing money from cigarettes or the tobacco products. So they are finding new ways to get more profit. So electronic cigarettes, that is one of the things that from which they can make money, and they can addict young people so that they continue to make profits, right? So as you all know that electronic cigarettes, they are also called as vaping devices or vape pens. They are all battery operated devices, and then they are used to smoke a flavored solution, which usually contains nicotine. And these have grown rapidly in popularity around the world. So everyone in the world, they are suffering from this new menace. I learned about it in 2012 in America, in University of California, San Francisco. So the Dr. Stanglens, who was conducting the program, he just told us about the electronic cigarettes. And immediately after coming back to India, we got it banned in my state, in Punjab. And later on in 2019, actually, Government of India, they agreed to ban all over India. But after Punjab, actually 18 states, they also banned electronic cigarettes. So consumers, they have a right to know about the products they are buying, and we need to be adequately informed about what we are consuming. But unfortunately, misinformation about electronic cigarettes is widespread. It is time to set the record straight. And I may tell you that quitting means quitting all nicotine products, and e-cigarettes that lead to supplementation and not replacement of nicotine. I'm talking about supplementation because people who use electronic cigarette, they continue to use the cigarette as well. Should I make it a slideshow? I'll try to make it if it's possible. Yeah. So is it better now? Is it better now? Please let me know.
It's still not playing in a slide.
The slideshow is not coming.
Slideshow is not playing. So I'll stop sharing. And Dr. Wasim, can you just ask someone to please share from your end if
Sure,
I
sir.
stop sharing? So there may be some problem with my slideshow. So Dr. Wasim, please try to.
Let me just try. Yeah.
So you have my PowerPoint with you, no?
Yes.
So electronic cigarettes, actually, it's a you can say it's a passion with me, and we have been able to control this menace because we have a very comprehensive act, which is called as Prohibition of Electronic Cigarette Act in India. Though the enforcement of the law is not that good as anywhere in the world. Actually, I just visited Switzerland and I visited Thailand. So they are all facing the same problem of enforcement of all kinds of law, including this prohibition of electronic cigarette, but they may be naming it as something else. Yeah, please, can you change the slide?
Yes. So I think you are here.
The next, yeah. You can, yeah, this is okay. So this is the first myth that e-cigarettes, they are not associated with any harms. So, but I may tell you the fact is that these are not harmless because they may contain formaldehyde, they may contain tobacco-specific nitrosamines, they may contain nicotine, as we all know. They contain heavy metals, they're ultrafine particles they have, and the short-term effects are the elevated heart rate, elevated diastolic blood pressure, and respiratory symptoms. That these are the short-term effects, and they are also linked to cell death, reducing lung function, stiffness of the arteries, and increased risk of cardiovascular disease, and even they may cause metabolic syndrome. Next, please. Yeah. So the second myth is that e-cigarettes are 95% less harmful. And the statistics that came from a research paper which was published in 2014. And despite the authors of the paper noting that they lacked hard evidence to support a 95% statistic, it continues to be published and used in defense of electronic cigarette more than 7 years later. So I think you all must have gone through this 95 percentile less harmful agenda of the e-cigarette proponents. So e-cigarette products, they are available today, they are widely different. This study was done in 2013 actually. And now the e-cigarette products are entirely different. Most of the researchers who attended the meeting where the statistics was created were supporters of the e-cigarettes, and some were funded by an organization with links to the tobacco industry. And we simply cannot trust the words of the people with a vested interest. So as you all know that the e-cigarette industry, it is not different from tobacco industry. So most of the tobacco industries, yeah. So they are producing like these electronic cigarettes. So they are not much different. Next, please. Yeah. So the third myth is that e-cigarettes can help people quit smoking tobacco cigarettes. So there is an evidence to suggest that these significantly increase smokers' urge to smoke tobacco cigarettes. So instead of creating tobacco cessation, the urge to smoke tobacco cigarette is more. These may be associated with cigarette smoking relapse. So when you try to promote tobacco cessation, or you motivate a person to do tobacco cessation, so the chances of relapse are more if they continue to use electronic cigarettes. And dual use, it is a common among smokers. So whenever the kids, they have money, they buy electronic cigarettes. When they have lesser money, they may buy those tobacco products. So these may serve to compromise quit attempts. There is an inconclusive evidence of the efficacy as quit smoking aids. As you know, as we all know that finally any product that is considered therapeutic must be approved as such by either FDA or there is DCGI as in India, that is a Controller General Drug Controller General of India, DCGI. Yeah. So it has to be approved. Any cessation product has to be approved. And I'm going to tell you that nowhere in the world these products are approved. I don't know about UK because they are the main proponents of the electronic cigarettes, but nowhere else these products are approved. We must not be persuaded by the anecdotal reports of individuals quitting smoking with the aid of electronic cigarettes. To date, the assessment indicates that e-cigarettes use contributes to more population level harms than benefits. The population harms because the second smoke is produced by the electronic cigarettes as well, and they contain nicotine, they may contain ethylene glycol, they may contain ultrafine particles, then formaldehyde, nitrosamines. So they are not safe products. So as far as the second-hand smoking is concerned. Next, please. So the fourth myth is that kids or the adolescents who use electronic cigarettes, they don't smoke. So the fact is that the use acts as a gateway to tobacco. As we call that, nicotine is a gateway to other drugs. And electronic cigarettes, they are gateway to tobacco smoking. So e-cigarette use is linked to tobacco cigarette use among adolescents and young adults who have actually never smoked. And proponents of the electronic cigarettes, they often criticize this evidence, claiming that smoking rate is in adolescent is decreasing, but they don't tell that smoking of e-cigarette is increasing in kids and adolescents. Those who use electronic cigarettes and then take up smoking, they were always going to smoke, but they just happened to start using electronic cigarettes first. So I think it's not a good proposition to promote electronic cigarettes as a cessation device. These claims, like much of those made by electronic cigarette advocates, they have been already debunked. World over, they have been debunked, but still these evidences, the created evidences, they are being used by the e-cigarette program. Next. Can you, yeah. So the fifth myth is that the e-cigarette industry, they do not market to the children and non-smokers. The tobacco, but the fact is that the tobacco and the e-cigarette industry, they need a new population, as I told earlier also, to for their own profits. So they definitely promote these products for kids and non-smokers. New youth-oriented e-liquid flavors like bubblegum, popcorn, Fruit Loops, unicorn milk, they are easily available. So now actually it is said that 22,000 flavors are available for electronic cigarettes. The industry also uses appealing e-liquid packaging, cartoons on the labels, or e-liquid boxes that resemble fruit juice cartons, and develops e-cigarettes that resemble USB drives, like asthma inhalers, like pans, remote controls, and even hoodie drawstrings. Some other devices, they are just like hoodies, and you can just use electronic cigarettes, and then but it looks like a hoodie. So on top of this, there's a research to suggest that ads for electronic cigarettes, they feature themes which are appealing to the youth. Next, please. So these actually pictures, they were shared with me by Mahidol University in Thailand. So you can see these are called as toy pots there. So you can easily make out that these are not meant for the adults. They are meant for the kids and for the youth. And there is another slide. So I could find these actually toy pots in many of the shops in Thailand. Next, please. So these are some of the pods which are available, and you can just make out that only kids can be attracted to these. So smoke-free word is the aim of promoting e-cigarette use by the industry. This is one of myths. And I may tell you that leaked internal strategy documents from one of the biggest tobacco companies in the world, that is Philip International, they suggest otherwise. These documents state that to ensure its corporate survival into the future, PMI needs to achieve two primary objectives, that is shaping public opinion and playing the political game. So as part of this guide, the e-cigarette use tobacco industry hijacked behavioral science by funding independent research. So you now see that many of the organizations, they are being funded by PMI. That smoke-free foundation is there now, Foundation for the Smoke-Free World. So they are financing independent research, but they don't tell that there is a conflict of interest, that they're being funded by the tobacco company. And e-cigarettes are part of the big tobacco's product diversification strategy to deliver new and upcoming nicotine delivery devices, especially those who have maximum appeal to the young people. Next, please. So if the e-cigarette use and tobacco industry goal was to genuinely support smokers to quit and exit the market altogether, they must stop making these tobacco cigarettes. But that is not the case. Ultimately, the goal of e-cigarette use, tobacco industry, is the maximization of sales and profits, and which is contradictory to their harm reduction mandate. So Dr. Wasim, if you allow, there are 2-3 slides regarding harm reduction, if you allow, otherwise my presentation is finished.
Sure, sir. Please go ahead.
Okay, next, please. I wrote an article regarding this harm reduction in a journal. So I'll be talking about that a little. So the term harm reduction was initially used in relation to reducing the harm from addictive drugs, but now the tobacco, the e-cigarette industry is using the term to promote e-cigarettes touted as cessation products, as these are absolutely less harmful. So as I've already told you that the harm reduction is nothing, it is just supplementation and it is not replacement of the nicotine. So tobacco cessation, that does not mean addiction to another addictive substance, whether in the e-cigarette as nicotine in chemical form. So harm reduction generally means a reduction of the harm at an individual as well as community level, as I told you. So there's no reduction in harm at the community level also because of the secondhand smoking. There is also not much evidence to prove that the heat not burn products or heated tobacco products, they are helpful for tobacco cessation, as being promoted by now Philip Morris and many other companies. So WHO recommends heated tobacco products, they should be treated and regulated as tobacco products. Ends are harmful to the users, minors, and adult non-smokers, and potential bystanders who are exposed to the second-hand smoke of the electronic cigarettes. So because most electronic cigarettes, they contain nicotine, their use by youth can lead to addiction and can harm the developing adolescent brain, which disrupts the attention and learning. Next, please. Can you move slide, please? Yeah. So I think we can conclude by saying that the public in general and the senior officials of the government, they need to be sensitized about the fact that the nicotine addicts, they need to quit the use of the tobacco or the nicotine in all forms. And quitting does not mean replacing an addicting product with another addicting product like electronic cigarettes. The harm reduction is a misnomer, as no newer tobacco or nicotine product is free of harm and also may promote dual use. And Dr. Wasim, I may just request you that you may ask government to look at our, there was a white paper published by ICMR India. So you can just have a look at that white paper. And also you must read the Prohibition of Electronic Cigarette Act. And that is a very, very comprehensive act because it includes electronic cigarettes, it includes heated tobacco products, and any electronic device which can be used for addiction. So I think Pakistan would do a good job if they can adopt India's comprehensive ban. And I tell you, the comprehensive ban is the only answer to electronic cigarettes, because partial bans, they are no good. They have been tried in many countries and they have failed. So thanks a lot.
Thank you very much, Dr. Rakesh Gupta. Your presentation was more of like an eye-opener for all of us, and the suggestion about white paper is very valuable for us. With this, I thank all the attendees also. I mean, it's not the end of our discussion, it is ongoing, but I just wanted to acknowledge the participants over here, especially the Indian side. We have Dilip Acharya, Ms. Sonal Bhatia Siddhi, and Surbhi Jindal. Before going to the next speaker, I just wanted to give a small sort of introduction about her. This is Dr. Aruna, and Dr. Aruna is a dental public and health professional and tobacco cessation specialist. And she will talk about the global and regional best practices in cessation and what strategies could be adopted to target the largest segments of population. And she would also talk about self-motivation and commit to quit tobacco use. With this, I would request Dr. Aruna to please take over the discussion. You need to unmute yourself, please.
Am I audible now?
Yes, loud and clear.
The screen is visible?
No.
Not it?
Now it is visible, yes.
A warm good afternoon to the respected panelists and the attendees for this webinar.
I'm speaking on the effective tobacco control measures. So like here, offer help to quit tobacco use. So I don't say that this component has been orphaned, but everywhere like the best practices are also available. But here what we need to do is to focus on the MPOWER tobacco control measure, wherein O, which is the deficient one, needs to be focused and amplified, and utilizing the more of the opportunistic opportunities which are available. And Article 14 of the WHO FCTC states each party shall take effective measures to promote cessation of the tobacco and use and adequate treatment for the tobacco dependence. Each party shall design and implement effective programs aimed at promoting the cessation of tobacco use. And guidelines are intended to assist the parties in meeting their obligations under Article 14 of the WHO FCTC. So what is the tobacco dependence treatment? The indicator of achievement in treatment for tobacco dependence is based on whether the country has available NRT, smoking cessation support, reimbursement for any of the above, a national toll-free quit line. National toll-free quit line is included as a qualification only for the highest category. Reimbursement for tobacco dependence treatment is considered only for the top two categories to take restricted national budgets for many lower income countries into consideration. The top three categories reflect varying levels of government commitment to the provision of NRT and the cessation support. So the desire to quit is high, but the support remains deficient. So the tobacco control policies in many countries have successfully helped the people to make the quit attempts. According to the GATS, over 60% of the smokers indicated that they intended to quit, but over 40% had attempted to quit in the 12 months preceding the survey. While this is encouraging, but support for the quitting remains low. Quitting tobacco has instant benefits. Health benefits of tobacco can be felt within the minutes or within the hours up to 15 years. So here, like since the oral cavity is the route of administration of the many of the tobacco products, so it will act as a valuable feedback measure also to identify the indicators of tobacco use, and as well as what would be the benefits if they quit the use of the tobacco. And here, like you can see that if a person has a oral cancer, smoking is the leading cancer, the smoker is at 5 to 10 times more likely to develop oral cancer than non-smoker. After 5 years after quitting smoking, the risk of developing oral cancer is cut in the half. And leukoplegia, quitting smoking and smokeless can reduce the risk of developing leukoplegic lesion. Periodontal disease, quitting smoking reduces the risk of periodontal disease over time and improve the treatment outcome. And melanosis, within 3 months after quitting, darkening of the gum will in most cases disappear. So it needs to be like other effects on the second-hand smoke exposure also need to be incorporated, and whatever the dental treatment or the caries or the clinical outcomes and the benefits gained by quitting the tobacco needs to be strengthened. Support is vital to quitting. Nicotine is so addictive that quarter of the teenage can become dependent on trying the cigarettes, and after smoking 5 packs, nearly 60% are dependent. Most people who use tobacco regularly do so because they are addicted to nicotine. This means they can benefit greatly from a range of effective tobacco cessation interventions. Without cessation assistance, only 4% of attempts to quit tobacco are successful. Proven cessation medication and professional support can double the tobacco user's chance of successfully quitting, and they can be broadly categorized into behavioral and the pharmacological interventions. And here, like the combining both behavioral and pharmacological interventions is more effective and can double the chances of successfully quitting. Behavioral interventions are efficient and present an opportunity to reach the potential quitters. When a tobacco user visits a primary or a special care service, it presents an opportunity for the healthcare worker to offer or provide them with a personalized counseling. The brief advice from health professional given as part of routine consultation or interaction makes efficient use of the existing healthcare system. The toll-free quit lines are another convenient way for potential quitters to access brief and potential intensive behavioral counseling. Those that use the quit lines increase their absolutely quit rate by 4 percentage points, which represents a doubling of success compared to those who quit without the assistance. This rate can be further increased if the quit line is proactive and the counselors make follow-up calls to the potential tobacco quitters. Recent app-based interventions for cessation are promising, with text message intervention increasing the absolute quit rate by 4%. The pharmacological interventions are diverse and can work better in combination. The effectiveness of pharmacotherapy to assist quitting tobacco is generally higher compared to the people who did not use any of the interventions. The quit rate increase range from 6% for a single type of NRT to 15% for varenicline with a combination NRT and a non-NRT one. Pharmacotherapy cessation interventions include NRT as well as medications that do not contain the nicotine but act to alleviate the tobacco withdrawal symptoms. Combination more than one NRT, the patches and the fast-acting form. So one is for the steady maintenance through the patches, and two for the either the nicotine gum or the lozenge to overcome the breakthrough cravings can increase the NRT effectiveness. 90% of the parties had NRT legally available in their jurisdictions. 2/3 had bupropion and varenicline available. Other pharmaceutical products have also been tried like cysteine and nortriptyline. Disappointingly, however, number of people protected by this has been offset by the 3 countries, Australia, El Salvador, and Senegal, representing 48 million, dropping out of the best practice in the same period. Out of the 4, you can see here, like, so India is one of the countries with the highest level of achievement, with having the best practices in tobacco cessation. So here, like, you can see that the 17 high-income countries and 9 middle-income countries offer comprehensive cessation support. None of the low-income countries offer best of the tobacco cessation practices. Globally, almost all high-income countries, 89% offer at least partial coverage of the cost of the cessation service, and most of the middle-income countries do the same. 18% of the low middle income countries offer the cost coverage for the services. The 32 countries that provide no cessation support at all. These numbers show that while work has begun, there is still much more to be done. So you can see here, like, over 30% of the over the year from 2007 to 2020, like whenever the cessation programs like offer help to quit the tobacco, it has increased from 5% in 2000 to 27% in 2020. So over 30% of the world population are covered by comprehensive cessation services. As of 2020, their comprehensive tobacco cessation services are in place for 2.5 billion people in 26 countries, or 32% of the world's population. Demand for cessation service is high, and this must be met. Since 2018, the number of countries offering the comprehensive cessation service increased from 24 to 26, and the portion of the world's population covered by the service is 31 to 32. The 5 countries with a combined population of 129 million, Austria, Cook Island, Jordan, Philippines, and Tonga, began offering comprehensive tobacco cessation service in the past 2 years. So here you can see that the 15, like the best practices, the national quit line and the both NRT and cessation service cost covered are represented here. And as far as the demand is concerned, like none of the 55% of the low income countries does not have none of the cessation services. And in the middle income countries, this gap is of 11%. And in the high income countries, the gap is of 7%. As far as the Southeast Asia is concerned, so the tobacco, while progress has been, you can see that in India, as one of the best tobacco cessation practice here. And in the Southeast Asia region, the Nepal is the one which the country does not have any of the cessation support from the MPOWER package. While progress has been slower in O than any other MPOWER packages since 2007, best practice adoption of cessation services nonetheless increased from 10 countries, 5% of the world population in 2002 to 26 countries, that is 32% of the world population in 2020. The population offered best practice cessation services in 2020 is 6 times that was in 2007. 67 countries, the home to 2.2 billion provide cessation package that are missing only one element to achieve the best practice implementation: a national toll-free quit line, cost coverage of INATI, cost coverage of cessation services. So here you can see the gaps in the utilization of the health services and the motivation of by the percentage distribution of current tobacco, smokeless tobacco users by interest in quitting smokeless tobacco, GATS, according to the GATS 2016 and 17. So here, only the we have many, as far as the motivation stage is concerned to quit the tobacco, we have many, the basket of the pre-contemplators are high. Those who are thinking about quitting in the will not quit in the someday, not in the 6 months. So if you see here, so here those who want to quit but not in the next 6 months. So what is the percentage? And as far as the comparison of even with the different forms of the tobacco also, you can see that here, people who are planning to quit within the next 6 months are only 7.8%. And thinking about quitting in the next 12 months are 11.7%. And those who are will quit someday, but not in the next 12 months are 30.2%. And we have happy tobacco users, 47.8% of tobacco users who are not interested in quitting the tobacco. And even if you compare it here with the smoking and the smokeless tobacco users, so we have the people if you compare even the duration of stopping a cigarette, BD and smokeless tobacco use. So here you can see that less than 1 month. So the people could achieve the quit tobacco status. It was high among the smokeless tobacco users, and followed by the cigarette and the BD. The penetration of different methods to support the cessation remains low. Most users are attempting to quit, but without any support. A small proportion of smokers even make a wrong choice of switching to smokeless tobacco as an approach to quitting. Most users who are attempting to quit are unsuccessful. So we will be having, since the smoking to smokeless form switch over, then we'll have the more dual users who use both the smoking form as well as the smokeless tobacco. The quit ratio is 5.8 for smokeless tobacco compared to the 16.8% for the smoking. Evidence to support suggests the cultural acceptability, normative attitude toward tobacco use, and lack of understanding of the health effects and addictiveness of SLT are the factors that have influenced the SLT use among the Indian communities. Murthy Pital's study in 2018 studied the perception of SLT users and healthcare providers regarding the prevalence of SLT in the community, awareness about its adverse effects and the challenges for cessation. Users and the service providers were more or less regarding the same extent of SLT use in the community. There was inadequate knowledge of the harm from SLT use both among the SLT users and the healthcare providers. Focus group discussion revealed high positive expectancies from smokeless tobacco use and a very low risk perception. There was a low demand for assistance to quit. The knowledge of the health effects of tobacco versus perceived harm on their own health varies among the combustible tobacco users and the SLT users. This misconception has safer led to the acceptability of these products when compared to combustible tobacco products, as reported by Mayuratra et al. Study. What are the factors like why initiation of tobacco use in women often occurs during pregnancy? A belief often held by the peer, family, and others that tobacco can provide positive health benefits, relief from common ailments and distress during pregnancy, such as nausea, vomiting, and constipation, as reported by the Shalini Singh et al. In 2020. So there are some innovative approaches also were carried out. One of them I am sharing it now. Designing a mobile health smokeless tobacco cessation intervention in Odisha, India, user and the provider perspective. This formative qualitative study explored the perception of tobacco user and the healthcare providers regarding developing a health intervention for SLT cessation. The qualitative study, using in-depth interview with the tobacco users and primary care physician and focus group discussions with the counselors, were carried out in 4 urban PHCs in Beharampur, Odisha from February to March 2020. The participants considered mobile message counseling to be helpful and acceptable. Not having a mobile phone and illiteracy were considered as barriers, while ease of access and rising popularity of social media application were considered as facilitators to the use of M-Health for quitting tobacco. The participants preferred messages which were pictorial, short, and simple in the local language and tailored to the individual needs. So what they conclude, this is the first study that provides evidence that within the Indian context, text messaging platform may be used for delivering SLT cessation intervention. The integration of a theoretical basis and the research finding from target users to the guide the future intervention development. So here there is one study wherein what are the factors which lead to the initiation and the initiation of the smokeless tobacco. This study was conducted in the urban setting of the 3 countries in Bangladesh, India, and Pakistan, who were exclusive non-smoking daily pass for the users of the smokeless tobacco were interviewed. So here, like the variables which were considered, the length of the smokeless tobacco use was more than 45 years among men in Bangladesh and 1.5 to 6 years among the women in India, and in Pakistan of about 10 years. And type of the smokeless tobacco used, pan with zarda was the most commonest one reported among the Bangladesh, and khaini and gutka were reported most common in Indians, and the Pakistan had shown the regional diversities, like and naswar was common at Peshawar and gutka was most commonly used at Karachi. The frequency or the times of the day the people use. So like women, the frequency of the smokeless tobacco use among women was less compared to the men. It was 4 to 8 times versus 15 to 40 times among the in Bangladesh, and 2 to 3 times versus 7 to 8 times in India, and in Pakistan like 5 to 6% versus 25 to 30%. So this shows that the frequency of use, the addictiveness to the smokeless tobacco products. The first daily intake was integrated into the early morning routine, while later be solitary with either with the family or else with the colleagues. And higher consumption was reported even in the social gatherings as the weddings, where even the non-users of tobacco were also present. And it was as the SLT products were widely available and affordable in all these countries, knowledge level also of ST product content varied. Participant offered detailed description while they could identify the 1 or 2 ingredients. Men typically had better knowledge through observation of the product preparation or recognition contents through smell and the taste. Low awareness of the ST systemic health risk, reporting the headache, chest pain, breathing difficulties, digestion problem, and feeling weak. While many noted that use during the pregnancy posed risk for the unborn child for some women, from all the 3 countries, they reported their SLT use during pregnancy without apparent adverse effects. The oral health risks were described as blackened teeth, halitosis, gum disease, mouth ulcers, oral cancer, and the risk could be mitigated by, and they had a myth that these risks could be mitigated if they rinse their mouth after the use. The knowledge of health risk and ingredients likely came from health warnings in the media, while for few of them it was an advice by the doctor.
I'm sorry, Dr. Aruna, for interruption, but would you please sum it up?
Yeah. Yeah,
Thank you.
I'm doing it. So brief tobacco cessation intervention. So now I'll just discuss about the regional best practices in the current India, a pan-India tobacco cessation intervention, a collaborative initiative, WHO initiative in the this initiative tries to reach out to the tobacco user of all categories who are willing to quit the tobacco use and support them, and by giving a missed call to 01122901701 and the registration, and also through the mail also. And National Tobacco Cessation Quit Line in India, it was started to a VP Institute in Delhi in 2007, and now it has been extended to the 3 more centers, by dialing to the National Tobacco Quit Line, the number 1800112356. So here both the proactive and the reactive calls are added, and here approximately 72 hours in a week have been were the working hours. And then here these promoting tobacco cessation in India by integrating brief advice in the RNTCP program. And then this was one of the model which was tried in the Vadodara in Gujarat. And then another one is also the brief advice cessation takes less than 3 minutes and consists of 5 And hypertension clinic service is a good opportunity for tobacco cessation among villages in the Bangladesh. So what about the tobacco cessation? According to the current status of tobacco cessation in India, they are available at the primary healthcare level, or more than 500 countrywide under the NTCP program, now converged under the National Health Mission along the National Health Program. The de-addiction services provided by the psychiatry department, units of the medical colleges, clinics run by the dentists are trained under TII of the IDA, TCC run by the private and the corporate health facilities, 321 dental institutes in the National Oral Health Program, to establish and run the TCCs run by the Dental Council of India. Nicotine replacement therapy as a form provision of pharmacological treatment facilities at the district level under NTCP and included in the essential drug list. Cessation counseling for the registered users through the National Tobacco Quit Line number 1800112356 regional quit lines. Cessation provided through 01122901701. So the sketchy, there are certain challenges. There is a sketchy delivery by the tertiary government health sector. The medical colleges observed lack of TCCs, and 70% of the entire health system. Suboptimal participation of the healthcare providers, lack of intent on the part of tobacco users to quit or to defer it now or in the next 12 months, lack of messaging through IEC or mass media campaigns under tobacco control efforts. The national health programs have been converged under National Health Mission, but do not have a specific mandate on the targets to be achieved under tobacco cessation delivery through their OPDs or the field activities, as included in the National Prevention of the communicable, non-communicable diseases in the cancer, diabetes, cardiovascular disease and the stroke, and National Tobacco Elimination Program. Inability of the medical insurance sector to integrate the use of the tobacco for a higher premium. Evidence-based approaches to quitting are available, but the challenge is they have been conducted in the US and the Swedish products, but no trial have been conducted in South Asian smokeless tobacco product, which differ markedly in their composition and addictiveness. So the novel smokeless tobacco products, the new challenges, Dr. Krishna sir already discussed about it. So one of the tobacco product which was introduced, the Chinese Khaini, as a snus marketed, but when they did the toxicological study, so they found the high level of tobacco specific nitrosamines in the nicotine in Chinese Khaini, a product marketed as snus.
I'm really sorry, Dr. Aruna, that I interrupted you many times, but unfortunately we are lack of time.
Finished. So I'm just sharing one of the outreach activities, wherein the health harms featuring the real story of the former tobacco user who suffered the tobacco-related oral cancer as a powerful messenger. Illustrating a real story may increase the media and public engagement with the message to quit tobacco. And the here the simple oral self-examination to identify the indicators of the tobacco use, and this was conducted for the transport workers who said that you see their face at least for the minimum of 20 times a day. So I thought we educated them on the identifying the indicators of tobacco use and asked them to install the Quit Tobacco app, WHO Quit Tobacco app, and to contact the National Tobacco Quit Line and the Cessation programs. So the opportunities do exist, and then we opportunity like we do correct. We can start with the one beautiful question like, do you currently use tobacco? Challenge is more people want to quit, but participation by the health provider still remains suboptimal. So we need to be the game changer to end the game of the to reach the end game of the tobacco. Thanks a lot.
Thank you very much, Dr. Aruna. You had a very, very rich presentation full of data and statistics, but unfortunately, we have a very limited time available. With this, I would now request Dr. Sahana Hagde Sethia, who's a professor, dentistry, oral surgery and medicine, Pune, Maharashtra, India. She would talk of behavioral tobacco cessation for school children. Over to you, Dr. Sahana. You have around 8 minutes available for your talk. Thank you.
Okay, can you see my screen?
Yeah, I'll stop sharing it.
Are you able to see my screen?
Yes.
Yes.
Okay, can I start? Okay, good afternoon.
Yes, please.
Yeah, good afternoon. I'm Dr. Sahana, and you'll find this language not very interesting to you because this is in our vernacular language, and this is what is prepared for the school children. I'm basically talking about behavioral counseling for the school children. Basically, I talk to them about the statistics and why you should stop using smokeless tobacco or why you should stop smoking. This is meant for the government school children in the municipality of Pimpri-Chinchwad in Pune, which is a city close to Mumbai. I go to the 19 schools run by the government, and there are about 250 teachers in these schools and 7,500 children. So what I noticed is that these are mainly consuming arecanut, otherwise called as sweetened supari in India, and this becomes a gateway. Some of them, of course, are using arecanut and smokeless tobacco as well. Some of them do smoke, and maybe they are a bit reluctant to tell me, but at times they do raise their arms and tell me, yes, we are using arecanut or sweetened supari, we use smokeless tobacco, etc. I do tell them about what are the contents of the cigarette and the smokeless tobacco. I tell them they have pesticides, they have, the products which are used for your toilet cleaning, such products exist, I tell them. What you see here is mishri. This is powdered tobacco that is available. And I noticed that some of the non-teaching staff in the school use this. They say we use this smokeless tobacco product, we apply it on the gums. Some of them say we use it for teeth cleaning, but basically what they do is they get addicted and they say they can concentrate better on their work once they've used the mishri. When I show this to the children, many of them close their eyes. They don't want to see this, but this is how I let them know that every organ of the body is affected, and this is how it leads to cancer, and this may eventually lead to death. I let them know that tobacco is addictive, and this is why at home they may see maybe their parent smoking early in the morning or using smokeless tobacco product early in the morning. This, I also show them pictures of the patients that we have seen at the dental clinic about this growth here. And I also show them the growth intraorally, that is where the smokeless tobacco product is normally placed. And I tell them that these are the products responsible for it. And these are the products used by the children, the sweetened supari or the arecanut used by children. And I tell them this will eventually lead to a precancerous condition called as oral submucous fibrosis, where limited mouth opening exists. And later on, they may have to receive injections or surgery for it. I also showed them this picture of the teeth, where the teeth look dirty if you continue to consume smokeless tobacco along with the arecanut. Here I tell them about the influence of the cricket stars and the movie stars in India. I let them know that, for them, it may be costing just 1 rupee or 2 rupee, or maybe a packet costing about 10 rupees or 12 rupees. But for these, it is their occupation. They earn a lot of money through these advertisements, and they're not going to consume these products. Okay, you see these surrogate advertisements, you see these advertisements luring these children, luring the youth into these products, especially by the cricket stars and the movie stars in India. I also let them know about the Cigarette and the Other Tobacco Product Act and the fines levied. Smoking in public places is not allowed. Sale of tobacco to and by minors is also not allowed according to Section 6A. 6B, according to 6B of the COTPA, the Cigarette and Other Tobacco Product Act, sale within 100 yards is punishable offense. I tell them that according to the act, the Food Safety Standards Act, any food containing the tobacco is punishable. I show them these pictures and I tell them these are the health warnings present, and if these health warnings are not present in the packet, especially with smokeless tobacco, in the rural areas, these health warnings may not be present. What is expected to be present may not be present, or it may be blurred. I let them know that this is also punishable. When they see these pictures, many of them don't want to see it, they just close their eyes. Sale to the children is punishable according to the Justice Juvenile Act in India, and the fine also amounts up to 1 lakh. Spitting, which is a nuisance to the public, and this is also a punishable offense. Second-hand smoke, exposure to second-hand smoke is also punishable, and the noxious gases that are released can cause harm to others, and this is punishable. And this is about the FSSAI Act that I told, that is sale of tobacco product in the form of food is against the law. I asked them about e-cigarettes, whether they are aware. There are very few students who tell me that they are aware of e-cigarettes and what I've noticed is smokeless tobacco use is more common among these. These children are from the lower socioeconomic status background. The parent may be using smokeless tobacco along with Erica nut at home. And here they are available as twin pouches. Since Gutka is banned in India, what the vendors do is they sell the tobacco and the Erica nut separately. Now, coming to the most important part, I offer help, and I can do it only in a group. Since I'm reaching out to so many children together, but I do ask them about how many of them are using. Some of them do raise their hands. Some of them are reluctant. They don't want to tell me the truth. I show them these pictures of the teeth. I tell them, see how beautiful one can look when the teeth are whiter in color as against when they are chewing tobacco. I ask the teacher also, and sometimes the teacher also helps me in identifying. I advise them to give up the habit. I talk to them about the health benefits, the social benefits, the financial cost, how much they would spend on tobacco if they continue the habit. I assess their need to be a non-tobacco users and what are the chances of quitting successfully. I try to find out that. And if I feel that no, they are unsure, they don't want to give up the habit, then I talk to them about the relevance of quitting, the health concerns, the risks, the acute and the long-term risks I talk about, the rewards that they can receive in the form of benefits, the roadblocks, mostly these are the withdrawal symptoms, and I repeat the entire thing again to them. And I also assist with the quit plan. Quit plan, I use the STAR approach for assisting them with the quit plan. I set a quit date for them, help them set the quit date for them. Tell them to talk to their family and friends. Usually these children are having these pouches of smokeless tobacco in their bags, and most of the schools have these checks. They may just randomly check their bags to see whether they are carrying any of these products with them. So in a way, the teachers are helping to see that the school is set tobacco free. I talk to them about their challenges, that they should anticipate challenges, and they tell them to remove the tobacco products from their bags, from their homes, etc. Now, practical counseling is also given to them by identifying the danger situation, which is usually the vendors which are present outside the schools. We have also involved the enforcement officials. We have sent letters to the State Tobacco Control Cell, the District Tobacco Control Cells. They've even acted upon these vendors. Practice behavioral coping skills, that is a delay in the use of the smokeless tobacco, drink water, and these are the ways in which they can delay this and try to quit the habit. Intra-treatment social support is given to them by being caring and concerned, and the quit lines are there, which I've already displayed on my presentation. And if they cannot, then I tell them about medications that are provided in the local government hospitals and also the local dental college, where it is mandatory for every dental college in India to have the tobacco cessation clinic. I arrange after helping them, assisting them, I schedule the follow-up. This is a research project which is going on for the 3rd year now. I keep seeing these children again. Of course, it is not one-to-one, but in a group, I see them one-to-one. And I talk to them, congratulate some of them on their success. Their dental checkup also goes on side by side. And if there is a relapse, I tell them it is a learning experience, so it does happen. And I elicit recommitment. Here I show them about the healthy lungs and the diseased lungs. They're able to identify them. This is already spoken about, I talked to them about minutes, hours, years, as they go by, how their health improves. The heart rate drops, the blood pressure drops, and how they can be free from stroke, cardiovascular diseases, and cancer eventually. I show this to them. I tell them, look, we are dental surgeons. We have 9 specialties in the dental college. And I, as a public health dentist, go out to the community to tell them why they should stay away from tobacco and what the oral surgery department does and how they operate on such cases to prevent the spread of disease to the other parts of the body. And when they see this, again, they don't want to see this picture because it becomes, too scary for them probably. But I do tell them this is what eventually happens. I show them these pictures which are done by the school children across India. I tell them about the signatures. These signatures, we put it up themselves because I collaborate with an NGO that is a local partner of the union, and we put up these signatures. And then I tell them to follow these 9 criteria. This, of course, the teachers are also involved in this, and all of them have to take the oath, which is again in the local language. Here I have put this quitline number, they always have it on the screen. These are some of the pictures of the school program that we have. This is how we make the presentation to the children. Here I'm seen talking to a non-teaching staff who is using Mishri to clean her teeth. Some of the teachers are so active, so involved. This is a painting on one of the school wall by one of the school teacher, and she has been assisted by their school children. Here, spitting is something which is commonly seen. They use smokeless tobacco and they spit here and there. We put up this sticker to remind them not to spit. Most of the schools have these smart boards, so we make the presentation using these smart boards, and the oath taking is a must. Here the school is, they've painted it as a tobacco-free school. This is something which was part of the competition. And recently when I went back to the school, I saw this, which was still present in the school. And this signage, we put it up on the vendors, which is close to the school. From the 19 schools, I noticed that 18 schools have vendors selling these products. Though it is a banned product, they are selling them near the schools, which is within 100 yards. During the dental checkup, I remind them by looking at their teeth, I can make out whether they are consuming the smokeless tobacco with supari or supari alone. Involvement of the teacher in the painting competitions. I involved an oral surgeon here, to let them know about how surgeries go on and, what happens, what are the ill effects. Here we have involved the school monitors and the teacher monitor and the student monitor to talk to the vendors nearby and ask them to stop selling tobacco, especially those vendors which are within 100 yards of the school premises. Thank you so much.
Thank you very much, Dr. Sahana. We have one more speaker, and this was all from the Indian side. Now I would request Dr. Noor Ovidiat. She is the Director of Cancer Control at King Hussein Cancer Center. She belongs to Jordan. Over to you, Dr. Noor.
Thank you. How much time do I have?
The floor is all yours. All the time is all.
Thank you. But I will try my best to do this very briefly because I think many interesting points have been made. So it makes my job a little bit easier now that I'm the one closing the session. So thank you once again for having me. And what I'm going to be doing is giving you an idea about what we have experienced in Jordan in terms of establishing cessation services. Perhaps share some learning lessons with what we have seen in establishing smoking cessation clinics. So I won't spend too much time talking about why we needed very much in an urgent way to establish tobacco cessation or smoking cessation services. And I will very briefly describe what we have so far, and then, what have we experienced, what we're still learning in this. So I will not go into too much of what has already been described. And I think we're all here because we all know the same thing about the harms of tobacco, and that not a single organ in the body is not impacted by tobacco. And we also know that it impacts non-smokers as well, and has a lot of repercussions in terms of non-health effects. It impacts marginalized and vulnerable communities in a disproportionate manner, because oftentimes they become iller and have poorer access to healthcare. And I think we're all in the same boat when we know that the tobacco industry targets us as countries that are still struggling with tobacco problems. And so on a global level, it is also an issue of inequity. And for us, a lot of things have been going on politically in Jordan that have made us more eager to establish and pay more attention to smoking cessation. One of them being the United Nations Sustainable Development Goals, which we have endorsed. So I think all of you are familiar with the situation in the Middle East, in particular Jordan, Lebanon, and Palestine. But we have a tremendous plague, I want to say, of tobacco use. This was not updated. We are now at 42% of smoking rates, tobacco use rates. And the bigger problem is that we're seeing things going from bad to worse. Things are not going down, or not at least plateauing. That every time we conduct a national survey, we find that our rates of tobacco use are increasing. I heard a lot as you were presenting about smokeless tobacco. In Jordan, we are still primarily conventional or combustible cigarette users, but we have a tremendous number of water pipe users now, shisha users. And of course, we are seeing vaping now commonly being used. I wanted to share how alarming water pipe use is now in women in Jordan, young Jordanian women. And you will see that in certain young age groups, that proportions are actually now more than doubled, which is very alarming. And our bigger problem is that it's not just tobacco. We also tend to have a poorer lifestyle than one would want. And this compounds or aggravates the issue of smoking, obviously, because we're being exposed to smoking at home. We have high proportions of tobacco users, and we're not engaging in recommended vigorous activity. We have a high obesity rate, especially among our women. And so all of these together mean that we really needed to make an effort to support smoking cessation. The bigger question was, we as healthcare practitioners know this is important, but are smokers interested in quitting? And thankfully, from the STEP surveys that have been conducted in the region, we know that the answer is a good yes for many Jordanian smokers. I think I don't need to argue for the feasibility of tobacco dependence treatment services. I think we take them for granted. We wouldn't think twice about using statins for primary prevention, or antihypertension medications for mild hypertension. And we wouldn't think twice about mammography. And yet we're always struggling to make the case for tobacco dependence treatment when it is in fact a much more feasible treatment and service to provide. I think we covered this, what are the different interventions that are available possibly, but in Jordan, what we have and what I will show you are two major interventions. We offer brief advice and intensive counseling. And I think, we should be more open to having an in-between. You could have a middle ground between brief advice and intensive counseling, depending on the practitioner that is providing this. So as I said, we have two types of cessation interventions, primarily at KHC and the Ministry of Health, but others are starting to provide some sort of help. KHCC, King Hussein Cancer Center, was the first site to offer comprehensive services. And these services have been in place since 2008 for our cancer patients, as well as anyone in the community who wants to seek that kind of treatment. The Ministry of Health used to have 3 to 5 clinics pre-COVID. The country during and after COVID opened a tremendous number in comparison to what it used to have, and now has 25 clinics operating. And one thing that was driving this is that the current Minister of Health used to work at KHCC. He was director of the Cancer Control Office. And so he knows very much how valuable having these services is. A lot of our partners in universities are establishing their own offices and clinics to be able to provide students, college students, with behavioral counseling because they have limited access to medications. And the same goes for other governmental entities like Greater Amman Municipality, which has its own services as well. In the past, pharmacies have tried to contribute, but nothing has been sustained. So this is, an overview of the 25 clinics that are available in Jordan. And because they are trained, most of them have been trained by us at KHCC. So they're trained to do largely what we do, which is intensive treatment, employing medications and behavioral strategies. What do we have? We've got nicotine patches, nicotine gum, varenicline, and more recently bupropion. At KHCC, we have additional options. We've got the nicotine nasal spray, the nicotine inhaler, and we have had bupropion for as long as the clinic has been established. And so one thing you will notice is that sometimes if there is a drug availability or medication availability issue, then you need to think out of the box about how to close that gap. And in our case at KHCC, we were able to get special import licenses to get some of these drugs. So is this enough, what we're doing? And I wanted to share a very hypothetical calculation with you. This is basically the number of current smokers in Jordan. I used STEPS data and I projected the number of smokers. And I used really humble assumptions. If 25% were interested in quitting, I would expect to see approximately 363,000 smokers. And if I wanted to operate clinics the way they're operating, I would hypothetically need to be seeing 140 smokers in my clinics currently. And we know this is not possible. So we need to do more. Obviously, we need to do more. Obviously, we need to focus on building a skill set. And this is what we've been working on both at KHCC and within the MOH, because we train most of the MOH practitioners. I think I think the slides may eventually become available to you. And I think we all know what a tobacco treatment specialist does, but this is what we were striving to do using the CTTTP framework for tobacco treatment specialists. And at the national level, what we sought to do was build capacity of our healthcare practitioners, make sure that we had enough medications, make sure that we had accessible sites, because not every clinic and not every Ministry of Health center is comfortable for us to set up smoking cessation services there. Make sure that these are covered services. Do we have a way to pay for them? And then most importantly, make sure that we have monitoring systems in line. And so we have been doing this. And unfortunately, in a perfect world, we would have made sure all of these were available and then started our clinics. But in an imperfect world, and for many different reasons, I think, it's beyond my talk today to go into them, maybe another time. But in an imperfect world, you will find that you will have to start certain steps of this before you finish the ones that you want to finish. Before you've created the perfect platform to launch your service, you will have to start. And this certainly is what we face. So this is, I think, something that we tried to follow, and we're still trying to implement. But bear in mind, again, that it's not always easy to do this in a smooth sequence and flow. I think one of the most important things to continuously focus on, and one thing that we always focus on when we're training our healthcare practitioners, is that if you don't have proper monitoring, referral, and follow-up, and if you don't have a screening system in place, then a lot of your effort is going to go to waste. We need others in the healthcare community to understand the importance of screening and the importance of AAR, so that appropriate actions are taken when people see smokers and they're referred to the smoking cessation clinics that we have worked so hard to establish. So, you know, I'm going to start closing now. What has helped us in establishing national services? The first and foremost is, as I told you, the interest at the level of the Ministry of Health, because of the current Minister of Health's deep commitment to smoking cessation and to tobacco control. I think one thing that really helped as well was international NGOs pressuring us to do more, and one of them was the WHO. The WHO was not happy with us not having enough smoking cessation services, and that added pressure that helped move things along. We had national TDT guidelines established, and that helped with us lobbying for the addition of the medications we needed to Jordan's national drug list. Otherwise, we would never be able to purchase these drugs on a national level. And finally, the availability of a US certified training course, the training course we offer at KHCC, really intrigued and made our physicians much more engaged, because when you have that kind of international certification, they start taking the specialty and they start taking the skill set much more seriously. What we're still learning is that, especially in the first 2 years, that we are seeing and we will continue to see a fluctuating demand for TDT services, as well as a fluctuating availability of healthcare practitioners and of medications. And this is because in any governmental health service, capacities are already at their limit. I don't think there's any governmental health clinic that will tell you they are comfortable and that they're not overwhelmed with people. I think we're still to this very day discussing, should this be a standalone service? Should this be integrated with other services? So should it be the smoking cessation practitioner in their own clinic, or should it be the internist or the family practitioner seeing patients for other reasons and then providing smoking cessation? And there is no easy answer, because the healthcare system is so overwhelmed and busy. And I think one thing that we've learned is that if we don't lobby for supportive staff from the very beginning, we lose our chance of asking for them again. And so I'll give you an example. So far, what we've done is we have been training physicians, but physicians are telling us we need nurses, we need pharmacists to be on top of things with us. And we have still not started doing that, but we should have started from the very beginning by saying, look, this is a multidisciplinary effort and team, and the physician can't do it alone. I think we need to give physicians time, because this is a learning curve, and they have very demanding schedules, especially if you are not including supportive staff in your training. We need to agree on the documentation system from the very start, because otherwise there's going to be so much variability in how each physician is comfortable in documenting their interventions and their outcomes. And you know, we all talk about free care, and right now it's free. And I heard from you that, you know, you were seeking to find ways to avail NRTs in Pakistan, and they're very expensive. They're also very expensive in Jordan. And I think we need to ask ourselves the very difficult question: should they be free, or should we impose co-pays? Because in the long run, smokers who quit are also saving money. And there is no right answer, because we find that our smokers stop coming if we tell them. We experience this in KHCC. If they know that it's not free, because in KHCC it's not free for non-cancer patients, they don't come. Whereas if it's free in the Ministry of Health, they will go. We need to accept that not everyone is interested in this, and that's not our goal, to reach every single smoker. Our goal is to help smokers when they see that they need to quit. We need to accept that different community groups will react to this service differently, and not everyone using tobacco wants to quit. So water pipe smokers are the big example. Water pipe smokers have far less interest in quitting, and this is why we go back to really providing this largely to cigarette smokers, combustible cigarette smokers. We need to have aligned impressions of what the service is, because what we found was that the clinic physician had his own or her own impression about the importance of this. The center director was sometimes not supportive of the clinic physician, and this was a problem. And the community was not always cognizant of what needed to be done. So we would have physicians that say, look, people are coming and saying, give me the medication and I want to go home. And we all know that this is not how tobacco dependence is treated. It's a behavioral, lengthy approach to treatment, and medications come just as a support for behavioral therapy. So we are still suffering from this misalignment of what smoking cessation services should be. And these definitely need for us to have well-developed campaigns and well-selected practitioners brought in to provide this service. And we, of course, also need many different stakeholders to be on the same page about this. I will stop by saying we also need to understand that these services may need to be customized. And we saw Dr. Sahana talked about kids. We know that kids have their own considerations and criteria about how to provide such services. And so we need to be open to this when we're thinking about national smoking cessation services. And so I will end at that. And I tried to do this very quickly so that we don't go over. I think we're already over, and I apologize.
Thank you very much, Dr. Noor, for these very valuable suggestions and valuable inputs also. Now I would request the last speaker for his closing remarks, and he's Dr. Khurram Hashmi. He's the technical lead of the Pakistan chapter of Vital Strategies. Over to you, Mr. Khurram.
Thank you, Wasif. I also represent the Union for its tobacco control work in Pakistan. Thank you, colleagues. In conclusion, I would like to express my sincere gratitude to all of you who have joined us today for this insightful and important webinar on the urgent need of tobacco cessation in countries like MPOWER, Pakistan, and India. Our discussions have shed light on the critical health and socioeconomic challenges posed by the tobacco consumption in these regions. And we have learned, thank you very much to our colleagues, that the prevalence of tobacco nicotine use remains alarmingly high, leading to a myriad of health issues and placing immense strains on our existing public health systems or lack of. The need for a collaborative approach cannot be overstated. This is what we have come to recognize. Only by working together on a regional level can we effectively counter this challenge and make a lasting impact on the lives of countless individuals in our land. So it becomes vital that we emphasize the importance of producing evidence-based research and data that clearly demonstrate the urgency of the situation. Our governments needs to be presented with irrefutable facts to recognize the imperative to develop comprehensive systems and mechanisms bolstered with adequate resources aimed at training professionals as well as the smokers in their journey towards cessation from tobacco. We must also be cautious about the concept of the harm reduction products, as highlighted by our colleagues in their presentations, such as e-cigarettes, and ensure that our efforts remain centered on scientifically proven methods of the cessation. And while the innovation has a role in public health, it is indeed our responsibility to prioritize solutions that are proven to be safe, effective, and sustainable, keeping in view the long term. And this, Dr. Sahana, Rakesh Sahab, Dr. Rakesh Sahab, and Dr. Noor have been pointing out, among other colleagues, that by raising awareness, as well as fostering cross-border collaborations and generating robust evidences, we can collectively pave the way for a healthier smoke-free societies through behavioral changes, as well as through comprehensive systems to provide assistance to those who need this. So our mission doesn't supposed to be end with this webinar. It is a call of action for all of us to continue advocating for a change and pushing for policies that prioritize the health and well-being of our communities. Once again, I extend my heartfelt gratitude to each and every participants, particularly our respected panelists, for their invaluable insights and engagements today. And this is a common belief. I can confidently say that together we can make a significant difference and contribute to a future free from the grip of this tobacco or nicotine addiction. So thank you all, and especially SDPI for providing us this brilliant platform for sharing of experiences and learning opportunities.
Thank you, Mr. Khurram Hashmi, and thank you all the panelists. And we are cognizant of the fact that all the inputs were really very valuable, but we are pressed on time because it's an online forum, and of course we have to be, little cautious about it. Thank you very much once again, all the participants and all the panelists for joining in for this very important discussion. Take care of yourself and people around. Goodbye.